Primary health care refers to essential health care that is based on scientifically sound and socially acceptable methods and technology, which make universal health care accessible to all individuals and families in a community. It is through the full participation and at a cost that the community and the country can afford to maintain at every stage of the development, in the spirit of self-reliance and self-determination. In other words, PHC is an approach to health beyond the traditional healthcare system that focuses on health equity producing social policy. PHC includes all areas that play a role in health, such as access to health services, environment and lifestyle. Thus, primary health care and public health measures, taken together, may be considered as the cornerstones of universal health systems. This ideal model of healthcare was adopted in the declaration of the International Conference on Primary Health Care held in Alma-Ata, Kazakhstan in 1978, and became a core concept of the World Health Organization's goal of health for all. The Alma-Ata Conference mobilized a primary health care movement of professionals and institutions, governments and civil society organizations, researchers and grassroots organizations that undertook to tackle the politically, socially and economically unacceptable health inequalities in all countries. There were many factors that inspired PHC. A prominent example is the Barefoot Doctors of China. Goals and principles. The ultimate goal of primary healthcare is the attainment of better health services for all. It is for this reason that World Health Organization has identified 5 key elements to achieving this goal: reducing exclusion and social disparities in health, organizing health services around people's needs and expectations, integrating health into all sectors, pursuing collaborative models of policy dialogue, and increasing stakeholder participation. Behind these elements lies a series of basic principles identified in the Alma-Ata Declaration that should be formulated in national policies in order to launch and sustain PHC as part of a comprehensive health system and in coordination with other sectors. Equitable distribution of health care. According to this principle, primary care and other services to meet the main health problems in a community must be provided equally to all individuals irrespective of their gender, age, caste, color, urban, rural location and social class. Community participation. In order to make the fullest use of local, national and other available resources, community participation was considered sustainable due to its grassroots nature and emphasis on self-sufficiency, as opposed to targeted approaches dependent on international development assistance. Health workforce development. Comprehensive health care relies on adequate number and distribution of trained physicians, nurses, allied health professions, community health workers and others working as a health team and supported at the local and referral levels. Use of appropriate technology. Medical technology should be provided that is accessible, affordable, feasible and culturally acceptable to the community. Examples of appropriate technology include refrigerators for vaccine cold storage. Less appropriate could include, in many settings, body scanners or heart-lung machines, which benefit only a small minority concentrated in urban areas. They are generally not accessible to the poor, but draw a large share of resources. Multi-sectional approach. Recognition that health cannot be improved by intervention within just the formal health sector. Other sectors are equally important in promoting the health and self-reliance of communities. These sectors include, at least, agriculture, education, communication, housing, public works, rural development, industry, community organizations. In sum, PHC recognizes that healthcare is not a short-lived intervention, but an ongoing process of improving people's lives and alleviating the underlying socio-economic conditions that contribute to poor health. The principles link health and development, advocating political interventions, rather than passive acceptance of economic conditions. Approaches. The primary healthcare approach has seen significant gains in health were applied even when adverse economic and political conditions prevail. Although the declaration made at the Alma-Ata conference deemed to be convincing and plausible in specifying goals to PHC and achieving more effective strategies, it generated numerous criticisms and reactions worldwide. Many argued the declaration did not have clear targets, was too broad, and was not attainable because of the costs and aid needed. As a result, PHC approaches have evolved in different contexts to account for disparities in resources and local priority health problems. This is alternatively called the selective primary healthcare approach. Selective PHC. After the year 1978 Alta-Alma Conference, the Rockefeller Foundation held a conference in 1979 at its Bellagio Conference Center in Italy to address several concerns. Here, the idea of selective primary health care was introduced as a strategy to complement comprehensive PHC. It was based on a paper by Julia Walsh and Kenneth S. Warren entitled Selective Primary Health Care, an Interim Strategy for Disease Control in Developing Countries. This new framework advocated a more economical, feasible approach to PHC by only targeting specific areas of health, and choosing the most effective treatment plan in terms of cost and effectiveness. One of the foremost examples of SPHC is GOBI, focusing on combating the main diseases in developing nations. GOBI-FFF selective PHC approach consists of techniques known collectively under the acronym GOBI-FFF. It focuses on severe population health problems in certain developing countries, where a few diseases are responsible for high rates of infant and child mortality. Healthcare planning is employed to see which diseases require most attention and, subsequently, which intervention can be most effectively applied as part of primary care in a least-cost method. The targets and effects of selective PHC is specific and measurable. The approach aims to prevent most health and nutrition problems before they begin. Growth monitoring. The monitoring of how much infants grow within a period, with the goal to understand needs for better early nutrition. Oral rehydration therapy, to combat dehydration associated with diarrhea, breastfeeding, immunization, family planning, female education, food supplementation, for example, iron and folic acid fortification, supplementation to prevent deficiencies in pregnant women. PHC in population aging. Given global demographic trends, with the numbers of people aged 60 and over expected to double by 2025, PHC approaches have taken into account the need for countries to address the consequences of population aging. In particular, in the future the majority of older people will be living in developing countries that are often the least prepared to confront the challenges of rapidly aging societies, including high risk of having at least one chronic non-communicable disease, such as diabetes and osteoporosis. According to WHO, dealing with this increasing burden requires health promotion and disease prevention intervention at community level, as well as disease management strategies within healthcare systems. PHC in mental health. Some jurisdictions apply PHC principles in planning and managing the healthcare services for the detection, diagnosis and treatment of common mental health conditions at local clinics, and organizing the referral of more complicated mental health problems to more appropriate levels of mental health care. Background and controversies. Barefoot doctors. The barefoot doctors of China were an important inspiration for PHC because they illustrated the effectiveness of having a healthcare professional at the community level with community ties. Barefoot doctors were a diverse array of village health workers who lived in rural areas and received basic healthcare training. They stressed rural rather than urban healthcare, and preventive rather than curative services. They also provided a combination of Western and traditional medicines. They had close community ties, were relatively low cost, and perhaps most importantly they encouraged self-reliance through advocating prevention and hygiene practices. The program experienced a massive expansion of rural medical services in China, with the number of barefoot doctors increasing dramatically between the early 1960s and the Cultural Revolution. Criticisms. Although many countries were keen on the idea of primary health care after the Alma-Ata Conference, the declaration itself was criticized for being too idealistic and having an unrealistic timetable. More specific approaches to prevent and control diseases based on evidence of prevalence, morbidity, mortality and feasibility of control were subsequently proposed. The best-known model was the selective PHC approach. Selective PHC favored short-term goals and targeted health investment, but it did not address the social causes of disease. As such, the SPHC approach has been criticized as not following Alma-Ata's core principle of everyone's entitlement to healthcare and health system development. In Africa, the PHC system has been extended into isolated rural areas through construction of health posts and centers that offer basic maternal child health, immunization, nutrition, first aid, and referral services. Implementation of PHC is said to be effected after the introduction of structural adjustment programs by the World Bank.